patient's creatinine had almost doubled since admission yesterday. It was 1.8 upon admission and 3.2 now. I said, "What do you think about starting vasopressors and moving to the ICU?" Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today, we're going to look at a case of a patient with cirrhosis. This is the third installment of our liver failure series. So if you haven't checked out episode 108 on spontaneous bacterial peritonitis or 109 on esophageal varices, definitely go back and check those out. This week, we're going to pick where we left off, talking about another patient with another common complication of cirrhosis, hepatorenal syndrome. So I get called to the progressive care unit of our hospital. I arrived to find a 50-ish-year-old male, his skin warm and dry, and he was responsive but not at his baseline mental status per the nurse. She called because the patient's blood pressure was 80/40. She said, "He's been running low since his admission yesterday, and we keep bolusing him to keep his MAP above 65. I've just been waiting for a reason to call a rapid because he looks worse to me today than he did yesterday." When he started acting confused and not at his baseline mental status, I was like, that's enough. I'm calling a rapid. And I agreed. It sounds like this patient is declining since his admission from yesterday. And knowing that hepatorenal syndrome is a common complication of cirrhosis, I asked about his urine output. She said, "Oh, yeah, and he hasn't peed my entire shift. I bladder scanned him at noon. I got less than 100 mLs, and I've given him 1,000 mLs of saline and 25 grams of albumin. He should have more urine output than that, right?" I already notified the primary team, and they just ordered some labs. He's scheduled for a paracentesis later today, and I think they're just hoping that will help him. Okay, let's pause to review. So, how aggressive I am with the volume resuscitation depends on how symptomatic my patient is. Like if they're unresponsive and pale and diaphoretic, I'm pressure bagging that fluid in. But this patient was arousable and very responsive, just a little more lethargic than he was the day prior. He was not in any distress, his skin was warm and dry, and blindly administering fluid boluses to liver failure patients isn't always the best idea. So, since I didn't have to move into resuscitation mode, like the patient was obviously perfusing his brain, I decided to do a little further investigation to help determine my next course of action. About that time, the ICU residents arrived, and they wanted to give a fluid bolus and draw an ABG to determine the source of the altered mental status. Fortunately, those labs that the primary team had ordered had just resulted, so I directed their attention towards the patient's renal function. The patient's creatinine had almost doubled since admission yesterday. It was 1.8 upon admission and 3.2 now. I said, "What do you think about starting vasopressors and moving to the ICU?" Yeah, we're okay with lower blood pressures in, generally speaking, in liver failure patients. And yes, we usually address preload before afterload when treating hypotension. But when the kidneys are starting to fail and we've already given volume replacement, the priority is to get that renal perfusion up before there's permanent damage to the kidneys. So I started a norepinephrine drip and moved the patient to the ICU. Okay, so many nuggets to address from this scenario. I know this wasn't a sexy crashing patient like a lot of the case studies that I share on my podcast, but he sure had the potential to crash. And If he was given more fluids and not treated appropriately, he probably would have crashed later on in that shift. So the question now is, why were his kidneys shutting down so acutely? I mean, I have some ideas, but I can't prove anything. So he was initially admitted for his growing ascites. They were trying to diurese him until his pressure started dropping, and they went the other direction and were doing fluid resuscitation. So was he over-diuresed? I don't know, maybe. Or maybe volume overloaded? Possibly, like not diuresed fast enough? I'm not sure. Additionally, we know that ascites and spontaneous bacterial peritonitis often go hand in hand. So did he have an undiagnosed spontaneous bacterial peritonitis and the sepsis was exacerbating his vasodilation, worsening his renal perfusion? Possibly. Or was his ascites so severe that it was impending flow to his kidneys? That might have contributed. Or was he on nephrotoxic medications? Not sure. Didn't even get to check. So I don't know. They sorted all that out in the ICU once they could get further diagnostics and see how he responded to therapy. But I just knew that I had a cirrhotic patient who now had renal failure, and I wanted to save his kidneys. So let's dive into the pathophysiology just a bit. As we discussed in the first 2 episodes about cirrhosis, the liver's architecture is distorted, leading to increased resistance to blood flow. This causes portal hypertension, and the body responds to portal hypertension with systemic vasodilation, primarily mediated by nitric oxide, particularly in the splanchnic circulation. This vasodilation decreases the effective arterial blood volume, even though the actual blood volume may be normal or even increased. Another way to say that is that even though there may be enough blood volume, it can't reach all the vital organs because of vasodilation. Think about when you're trying to water your garden and the water coming out of the water hose isn't quite making it to the furthest portion of your garden. What do? Well, I put my thumb over the opening of the water hose. This constricts the opening of the hose, thereby increasing the pressure inside of it and allowing the water to travel under pressure to the desired location, the plants that are far away. The same concept is true with the blood vessels and blood pressure. So volume that isn't under enough pressure can't reach the end organs effectively. So when that vasodilation occurs because of cirrhosis, even though the volume of blood may be adequate in the system, there isn't enough pressure for it to make its way to all the organs that need it. The kidneys especially need pressure to get blood through that organ system. And the kidneys are so dramatic. Like, when they aren't getting the flow that they need, they tend to overreact a bit.
Hey guys, I'll get back to the show in just 1 second, but before I do, I have a request. If you have ever gotten any value from this podcast and you want the show to continue to grow, to access more awesome experts in the field, and to keep providing you with more nursing knowledge and inspiration, could you take a minute to leave a rating and a review? Those reviews on Apple and Spotify go a long way in getting this podcast in the hands of more nurses and bringing new guests to the show. And they just make my day to know that my stories and nerdy patho breakdown are helping other nurses thrive, or at least survive. So if you're feeling up to it, I'd love to see a rating and review from you. Thank you so much. Now back to the show.
To counteract that perceived low blood volume, the body activates the renin, angiotensin, aldosterone system and the sympathetic nervous system, leading to renal vasoconstriction. However, the kidneys can't function well in this state of reduced perfusion, and over time, the persistent vasoconstriction and the increased pressure demands on the kidneys result in progressive renal dysfunction. Additionally, if there's a large volume of ascites, this further puts external pressure on the vessels that bring blood to the kidneys and reduces blood flow to them, exacerbating the whole low perfusion state that they're already struggling with. So in summary, liver failure can cause renal failure, and this just adds one more obstacle for the body to overcome to move towards homeostasis. But here's the thing. Coming to the diagnosis of hepatorenal syndrome can be tricky because very often multiple pathologies can be present simultaneously. Renal failure doesn't have to be exclusively from hepatorenal physiology, or exclusively from acute tubular necrosis, or exclusively from a pre-renal source. All of these diagnoses exist on a continuum, and they can also all exist simultaneously. There are diagnostic tests that can kind of help sort through the differentials, like urinalysis, renal ultrasound, diagnostic paracentesis, along with trending the renal function as therapy is administered. But really, all of those sources of renal failure, like all of them, should improve if we can improve blood flow to the kidney. So that should be the goal. And how do we get better blood flow to the kidneys? By increasing blood volume with albumin and increasing the pressure inside the vessels to deliver that blood volume to the kidneys with vasopressors. So albumin and vasopressors. What makes the most sense to me is to do a point-of-care ultrasound or advanced hemodynamic monitoring to determine fluid volume status. So if the patient is volume overloaded, don't go crazy with more volume administration. Maybe focus your efforts on improving the blood pressure with just vasopressors. But if you put the ultrasound probe on them and their inferior vena cava is small or very collapsible, then they need that volume. Or if you give a little fluid bolus and their stroke volume increases along with their blood pressure, then they might need more fluid. So if in the ICU, adding vasopressin to norepinephrine has been shown very helpful in treating hepatorenal syndrome. And we're not shooting for the normal MAP greater than 65 for this patient population. We want MAPs in the 80s, with the current recommendation of get the MAP 10 to 15 millimeters of mercury higher than what their baseline was. So if the patient already has a baseline MAP of 80, let's be honest with ourselves, they probably don't have hepatorenal syndrome, because hepatorenal physiology is rooted in poor perfusion to the kidneys from vasodilation. And a MAP of greater than 80 doesn't sound very vasodilated to me. As far as the albumin, I couldn't find any consistent recommendation for how much albumin to give, but every source I found says you give a lot, and you give even more if they're going to go for a large volume paracentesis. Patients can also be treated for hepatorenal syndrome outside of the ICU with midodrine, octreotide, and albumin combined together. And obviously, we're going to hold any beta blockers that the patient was taking prophylactically during this acute stage of hepatorenal syndrome, as this could worsen blood flow to the kidneys. And we're also probably going to stop diuretics too. Little caveat, there may be the rare occurrence that the patient has hepatorenal syndrome from fluid overload, and that hepatocongestion is worsening the renal function. And in this case, and if you can prove it, then a combination of vasopressors and diuretics might be used. But for the most part, we're going to cut the diuretics. Okay, and finally, a good med review is in order to make sure that we stop any nephrotoxic medications that might be upsetting those oh-so-sensitive kidneys. Okay, let's review. Hepatorenal syndrome is a fairly common complication of cirrhosis. Due to the scarred liver, a cascade of hemodynamic changes causing vasodilation can actually lead to a compensatory response that causes renal vasoconstriction. Don't you just love when the body's trying to help and just gets it all wrong? It's kind of like when my 5-year-old wants to make dinner. And she's really trying to help, but ends up making cooking far less efficient and far more messy. And those kidneys, they sure do try, but sometimes they just make things worse for themselves. So treatments like albumin administration, along with vasopressors, aim to restore hemodynamic stability and renal perfusion by increasing the blood volume getting to the kidneys and the blood pressure sending that volume to the kidneys. So our takeaway as nurses: the development of hepatorenal syndrome dramatically worsens the prognosis for someone with liver failure. So prevention is far better than treatment. Pay attention to urine output and trend BUN and creatinine in your liver failure patients, and let someone know if you notice a trend in the wrong direction. Secondly, stay on top of that blood pressure if the kidneys are struggling. The little beans don't like too much congestion, and they also tap out when they aren't getting enough flow. They like it just right. So we will push the MAPs up a little bit higher than normal to try to salvage them when they are on the struggle bus. Be prepared to keep those MAPs above 80 if we are actively treating hepatorenal physiology. And finally, everything can go wrong with cirrhosis patients. In this episode, we just talked about how the kidneys might be affected, but they can also simultaneously have a raging spontaneous bacterial peritonitis or bleeding esophageal varices, or their ammonia might be critically high, or their electrolytes are dangerously out of whack, or they're bleeding from every orifice. This is a very complicated and challenging patient population to manage. But when we can turn things around for these patients and improve their quality of life and their chance for liver transplant, it's so worth it.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.